Thank you very much, Stephen. Thank you very much for the invitation to speak today. My talk today is going to be about the results of MAS2, and here are some of my disclosures. Surgery for mesothelioma remains a big deal, and parectomy decortication still remains the principal operation offered by all the Western guidelines published to date across the world. Now, with extreme conviction for recommendation of surgery, such as parectomy decortication, I adapt this from the Sagan standard to say that it really requires extraordinary evidence. But the evidence we have is usually far from, I was going to say extraordinary, but it's not really extraordinary. I was going to say mediocre, but no, maybe it's not mediocre. I think it's even far from credible because the randomized studies have never evaluated the efficacy or, in fact, any positive results associated with surgery for mesothelioma in a randomized setting. So unless you've been living underneath a rock for the last 6 months, you will know the results of MAS2, a randomized trial conducted by many of the people sitting here in the audience of 335 patients randomized to receive either surgery in the form of extended parectomy decortication and chemotherapy, or chemotherapy alone. I want to cut straight to the chase and get rid of all the foreplay. Here are the results. The results show, shock horror, that surgery was associated with worse survival. Yes, ladies and gentlemen, the surgery line is the red line, which is below the blue line. I mean, the MAS2 is in review process at the moment at the Lancet Respiratory Medicine, and some reviewers actually thought the curves were the other way around. So I'm just pointing out to you that surgery was the one that's below and not above. Some people say, hey, you're trying to pull a fast one on us because you got, stats and numbers and all that crap. And what actually the real situation is that there's no difference in survival. Look, the curves converge at 48 months. Now, I was looking at Dean's talk, and I was really fascinated to know that many of the randomized trials in mesothelioma show that mesothelioma, the interventions are actually not proportional. Because they're not proportional, we can't actually use one hazard ratio to summarize them all. In this case, we stuck to one p-value with a restricted mean survival time showing a reduction in survival of 1.9 months, which is statistically significant. Some people say that because the curves cross at 48 months, therefore we say that it's not that the operation is harmful, it's that there's no difference in survival. No, well, that's about as intellectual as saying in a randomized trial of 15 patients in each arm, there's no difference in survival because it's exactly how many patients are left in that 48-month period. So the bulk of the knowledge and the information that we ascertain are from the power of the study, which is at the front-loaded part of the curve, showing a significant worse survival. There is no criticism, doubts for this. We've gone through 3 rounds of reviews. We've done the first round of the reviews were over 44 pages in response to reviewers. And no one in the 3 rounds has criticized. We know surgery for mesothelioma has a 3.6-fold higher incidence of serious adverse effects. Quality of life drops, as you would expect with any operation. And at first glance, you say, well, the quality of life actually improves after a certain time, right? But no, there's a problem there in that there's a healthy cohort effect. In order for you to be able to report your quality of life, you need to be alive and well to come back to report it. When we look at EQ5D, which takes death into account and assigns it a 0 value, you can see that the real difference in quality of life in terms of utility was significantly poorer with surgery. So those are the results in a nutshell for MAS2. Now, what I would like to dwell for the remaining of my talk is the question that, are the results of MAS2 robust? Because, when we're confronted with evidence that challenge our deeply held belief, we're more likely to reframe the evidence than we are to alter our beliefs. Everyone wants to believe that surgery works. I want to believe that surgery works. Of course I do. But the issue of cognitive dissonance needs to be addressed. Were there issues in the inclusion criteria? Some of the reviewers came back to say, oh man, MAS2 is sucks because you guys put sarcomatoid. Are you stupid? Why would you put sarcomatoid disease in a randomized trial? Well, because people are already doing it. Hello? In America, people are saying, oh, well, with highly selected biphasic patients, if you select them really, really well, hey, man, they do really good. They survive all along. Despite ASCO recommendations that non-epithelioid disease should not be operated on, unless, of course, in a clinical trial. People think that the inclusion of sarcomatoid was a lapse or a flaw. Ha, ha, ha. There's a flaw in MAS2. I got you, man. You guys include sarcomatoid, idiots. No, these are pre-specified entry criteria, allowing us to ascertain if there was a differential effect, or in mathematical terms, it was a significant interaction. Because you can say very easily that you can't operate on this is really crap, you do really badly. But if the effect is the same, the outcomes with poorer survival have a better results. A simple analogy is for surgery for stage 3A, lung cancer. If you operate on 3A lung cancer and the effect of the operation is the same as stage 1 lung cancer, the magnitude of effect is the same. It's only if there's an interaction effect where something weird happens in this cell type and there is a statistical interaction, that proves that that doesn't really work for this disease subtype. And for the first time in the world's history of mesothelioma, we actually quantified and demonstrated a significant statistical interaction, which means that the same operation done with 2 different disease types actually yields different results. And the inclusion of a non-epithelioid was only 12% of participants. It was carefully monitored, and we wanted to strengthen the evidence base. So now we know for sure that you should not be operating on non-epithelioid disease. The next thing was, you guys, MAS2 is clearly flawed, participant selection sucked, staging sucks, you guys didn't do any staging, it was all awful. You guys didn't do PET, PET's mandatory now, everybody knows that. MAS2 was conducted between 2015 and 2021, and the very first guideline recommendations for the use of PET-CT came out in about 2018, and then slowly compounded after that. So it came out around the last 1/3 of the trial, and as you can expect, therefore, only about 40% of patients actually had PET-CT. Some people went on stage to criticize the trial design, that because we did not include PET-CT, this was not a standard of care. PET-CT was done in 38% of the surgery arm and 43% of the chemotherapy alone arm. So they said, aha, so your selection is flawed, because if you didn't do PET-CT, how would you know that it's equally balanced? And if you did PET-CT, the results would be better surgery, clearly, because you select better. When we did a subgroup analysis, or as mandated by the reviewers, we found that in the pre-PET-CT, which is on the left, where you had no PET-CT, nobody knew what the correct stage of the disease was, surgery did worse. And when you did include the PET-CT selection, guess what? Surgery did worse. Oh, well, so much for that hypothesis there. Well, there it goes. And then the next thing they said was, well, MAS2 sucks because you guys didn't stage the patients. You included N2 disease, N1 disease, you didn't stage them. In America, we like stage them. We use like meats, and if you have positive meat, we don't operate, you know? That's not true, because in American guidelines themselves, right, they recommend that surgery for mesothelioma can be undertaken with nodal disease as long as you do either adjuvant or neoadjuvant treatment, or even better, in a clinical trial. And we tick all 3 boxes. We did both neoadjuvant and adjuvant and in a clinical trial. The real question is, if your American guidelines specify you can operate even though you have N2 disease, why on earth are you wasting time, effort, money, complications, risk, and delays by doing a MEAD? Hello? At the end of the day, after we did MAS2, we found that the majority of patients indeed did not have N2 disease. This was the minority of patients. Around 7%, and about 20% actually had evidence of N1 disease. Another big issue was an imbalance in stage, because for example, T2, you've had some patients, 83% in the surgery arm, had evidence of underlying lung parenchymal invasion, so on and so forth. Now, we wanted to be as open as we can, and we include as much information and detail as we can. So for the T2 subcategories, T3, so on and so forth, we included all the subcategories in. And when you have a small number of patients in each subcategory, the numbers start becoming huge. So you get things like big gradients as numbers become smaller, because 1 and 3 becomes a 300% increase in the difference between the 2 arms. But people fail to understand that the T2 groups are balanced at baseline. So you have 21% with T2 in surgery, 21% in T2 in the non-surgery arm. And it's the parent category, the T2 designation, which actually defines your survival. So even if you have imbalances in the subcategories of T2, the actual prognostic impact is the same, and it's balanced. Really unfair criticism for MAS2 was that it was done in operations or done in surgeons and institutions of low volume status. Aha! That was quite a common wielded comment. Apparently, the number is 5. 5 a year dictates whether you're a high volume or a low volume center, and that was done by the IASLC Mesothelioma Task Force group, where they defined that if you had done 5 operations or less on EPPs, not EPDs, extrapleural pneumonectomies, you had a high incidence of ARDS. So then 5 became this magic number. We had 5 MAS2 sites, and we intentionally specified that we have at least 1 non-expert site. And the non-expert site, they averaged 3.4 cases per year. In the 4 expert sites, the average was 8.6, 14.3, 27.6, and 36.5, higher than some of the top volume American institutions. And in these centers, these were patients that were also randomized into medical treatment with MAS2, and also in the presence of a COVID pandemic that shocked the world. And despite that, they have actually numbers equal to other North American centers without any randomizations. Another issue that came up was that maybe the results were driven by imbalances in systemic treatment. You see, there were more patients in the non-surgery arm having chemotherapy, more patients in the non-surgery arm having immunotherapy, and therefore the study is imbalanced, and therefore your results are not valid. And what people don't understand is that the differences in the systemic treatments are outcomes. They are not baseline parameter imbalances. The differences in the willingness to give you treatment is about the intention to treat pathway. If you're randomized to surgery and you're too sick to have the full course, or you are too sick to have immunotherapy, it's not that your design sucks. It's because your operation sucks. And that's why patients can't actually get to the systemic treatments which they need to actually improve the survival. And having said that, there's no point in saying that less systemic treatments is bad because the patients couldn't receive it anyway. We did a sensitivity analysis, and we actually modeled the effect of systemic treatment, and we found that it didn't actually make any difference to our principal outcome. So here's another quote from the same book. Intelligence and seniority, when allied with cognitive dissonance and ego, is one of the most formidable barriers to progress in the world today. Amen to that, because we go on to talk about how about if we completely get rid of this concept that meso is resectable. How about that? What if we do that? If you did that, first 2 things we're going to do is you're going to increase the survival across the world by reducing the risk of death from surgery. And then you're going to push survival even higher up because now you're going to open access to systemic treatments which are currently not licensed for patients with resectable disease. So immediately, a cost-free intervention that improves survival and saves money at the same time. In conclusion, both MAS and MAS2 are randomized trials of cytoreductive surgery for mesothelioma, and they demonstrated a higher risk of death. They didn't demonstrate the operation didn't work. Just don't get me wrong here. They demonstrated that patients died because of the operation. That's a big difference. It's not your operation has no effect. Your operation is killing people. More serious complications, that's uncontested. Poorer quality of life, and at a higher cost, especially when we did the health economic equations for MAS2, compared if you were randomized to no surgery. But actually, cutting to the chase, come on, man, how robust are the conclusions of MAS2? I wish the study was positive. I'm a surgeon. I don't want to have hate mail. I do get hate mail every day from other surgeons from around the world. I don't want to do that. I didn't ask for it. I'm not defending the results of the study. I'm defending the trial design. And you can slag off the results as much as you want, but please criticize the trial design fairly. Center volume, staging, histology, and rather than accept the fact that randomization can create 2 equal groups, people are trying to think that maybe if you select and subselect and subselect and subselect above that, eventually, at some point, you will get 1 group that works. And here is the ideal subgroup, T1 to 2, N0, epithelioid only. And guess what? They also died more. So, by all means, don't believe MAS-2. Don't believe the results. I'm not pushing this to you. I'm not shoving this down your throat. You should further evaluate it, get more randomized trials. But until you do, MAS and MAS-2 represents the highest level randomized control trial evidence to date, whether you like it or not.